Hey guys, I'm Dr. Shubham Agarwal, and today I am going to continue the series of tachyarrhythmias. I'm going to discuss today how we will approach the patient with wide complex tachycardias. We will mainly concentrate on ventricular tachycardias, how to manage it, and also what we will do, what are the antiarrhythmic drugs and everything. We'll discuss about that. So let's start. So what is going to happen when you look at the ECG is that it's not very tough to make the diagnosis of ventricular tachycardia because it was usually said that anything that you see a broad complex QRS, label it as ventricular tachycardia. But no, that is not true. It has a proper criteria how you have to diagnose because broad complex tachycardias can also be seen in supraventricular tachycardia with aberrancy. So you always have to rule out. And why it is important to rule out supraventricular tachycardia with aberrancy? Because your treatment line will change. How? For example, in the ventricular tachycardia, which is a drug of choice, we all know it is amiodarone. But in supraventricular tachycardia with aberrancy, you cannot give amiodarone. You have to go on according to a AFib or AF letter in a way that you have to give beta blockers, diltiazem, and all that. But so the treatment lines differ, and it can be a deteriorating, even can increase the mortality of the patient. So we all should do it very, very clearly and crisply, and we cannot uh, make any kind of a mistake while diagnosing ventricular tachycardia or while diagnosing a supraventricular tachycardia with aberrancy. So a patient will give you a history. A supraventricular tachycardia with aberrancy will give you a history. The patient will be young. He will not have any prior structural heart disease, except he will have some kind of a family history. So when you'll ask more, the patient will be on the antiarrhythmic class 1C and usually on a pacemaker in the past, and the duration of the disease will be usually more than 3 years, which has been running in the family or being presumed to the patient. But in the ventricular tachycardia, none of such things will happen. The patient will definitely have underlying structural heart disease. Ventricular tachycardia हुआ ही as a complication है, कोई underlying structural heart disease है. He might be having some long-standing valvular heart disease. He might be having infective endocarditis. He might have undergone a recent MI attack. Anything will lead to a last complication, that is ventricular tachycardia, further leading to ventricular fibrillation. So underlying structural heart disease होना बहुत जरूरी. He might be on a QT prolonging drugs. He can be on a heart failure medications. Devices, in these cases, there will be ICDs, intracardiac defibrillators. Such patients will have the features of congestive heart failure. They might have some kind of a sternal incision, giving you the diagnosis of CABG in the past. So let's see further. So how will you get the clue that the patient is suffering from a ventricular tachycardia? Always remember this, and the diagnosis will be very, very easy. One, I will discuss what is a capture beat, fusion beat in the further slides, but remember these points. These will make your diagnosis of a ventricular tachycardia, and just don't say it's a broad complex QRS, so it is a ventricular tachycardia. No, justify your ECG with these points. First, the patient have a AV dissociation. There has been some kind of capture beat, or there has been some kind of fusion. Second, what you will see a concordance in the QRS complexes. All the QRS complexes will be the same direction in the precordial leads. Third, you will have that this is what we remember, that they have a broad complex QRS along with left axis deviation. And rest all we forget, and we don't know what is happening and what is not. Then there's also in precordial leads, you have a RS pattern that is known as a Josephson signs and Brugada sign. This we will see in the further slides. And in the downslope, you will have a slurred S wave. Again, we'll see which is a Josephson sign, which is a Brugada sign. Then you will have a RBB pattern, or you can have a LBB pattern. We all know where to see a RBB pattern. It has to be seen in V1 and V2. If it is a RBB pattern, there will be a broad basal QRS. Along with that, you will see a T-wave inversion. If it is a LBB, it will be most prominent in V5 and V6 with upsliding of S waves and bizarre QRS complexes. We'll discuss it one by one. So let's see, you can see the ECG. First of all, broad QRS आप किसको बोलते हो? If your QRS is coming in more than 3 small squares or its duration is more than 120 milliseconds. Fine. Okay, fine. Now you can see that first QRS is broad. Okay. Second QRS is broad. Fine. But third is becoming narrow. Again a broad and again a broad QRS. Okay. Now what is this narrow QRS between the two broad QRS? What is this? Something wrong is happening here. What wrong is happening? Let's see. What is happening here is that there is some kind of a premature ventricular contraction before the occurring of a broad QRS for tachycardia. And what has happened? There is a fusion of a P wave with a capture wave. So what they are saying is that we can see a P wave, we can see a P wave in front of a premature ventricular contractions. And this indicates that this is a product of a silent snore and ectopic ventricular focus. Simply आप फ्यूजन बीट को ऐसे रखो कि फ्यूजन फ्यूजन का मतलब दो चीजों का यूनियन हो रहा है. तो वो दो चीजें कौन सी हैं जिनका यूनियन हो रहा है? इट इज अ पी वेव getting a union with what? With a premature ventricular complexes. That is a fusion beat. Now, let's see something else. You can see a broad QRS, fine. Then you have a fusion beat, fine. Then again a QRS, a broad QRS, broad QRS. And now what you can see? You can see a negative QRS. What is this negative QRS? Which is narrow. So there's a narrow complex QRS. What is this? So what this narrow QRS negative is, this is a normal QRS coming between the broad QRS. What does this indicate? This indicates that there is a conduction through a normal ventricle. Now, what is happening? You are saying that yes, the ventricular tachycardia has occurred. Okay, fine, it has occurred. But कुछ part of myocardium तो normal होगा, कुछ part of ventricle तो normal होगा. तो जो normal ventricle होगा, वो अपना normal QRS तो देगा ना. So that normal QRS is your capture beat. So you should be very very clear. What is a fusion beat? What is a capture beat? Both will be narrow complex definitely, but a fusion will be a fusion of a premature ventricular complexes with P wave, and the capture beat will be a normal capture of a ventricular rhythm. Remember it like this. So next, then I discussed here that there is a fusion and a capture beat that is known as AV dissociation. Then I discussed that there are other features, that is a AV nodal dissociation. What are this? On JVP, you will see a Canon A wave, you will see a beat to beat variability and a variable S1. Again, you can see in this ECG, let's focus on first ECG, upper wala ECG. We are having all the broad QRS complexes, and then you can see a narrow QRS complex. There's a P wave with a premature ventricular complex, and again a P wave. So there's a fusion somewhere, there's a capture. So this is a normal QRS complex. Okay. Now we will come to this broad QRS complex, and there is a fusion of a P wave with a premature ventricular ectopic, which I have highlighted this red circle. So this will differentiate. यहाँ पे आपको P wave दिख रहा है ना? इस वाले में तुमको P wave दिख रहा है followed by a normal QRS complex. इसमें you cannot find a P wave. They have been fused with the ventricle, a ventricular ectopic. Fine. So next, what is concordance and what is discordance? Concordance means that all the QRS are in the same direction. Now let's look at this first image on the right side. All the QRS are positive, positive QRS, positive, Q, positive, positive. So all the QRS are broad and they are positive. So a positive concordance is a typical feature of what? Of ventricular tachycardia. And a negative concordance, here you can see a negative concordance. A negative concordance gives you a strong clue for ventricular tachycardia. You can see the QRS. All the QRS in this are what? They are negative. So a negative concordance, giving a concordance is a feature of a ventricular tachycardia. But if it is a negative concordance, it is a definite feature of ventricular tachycardia. Now next, what I was talking about Brugada and Josephson sign, we'll see this diagram. So let's first look at the upper diagram. What we can see that there are broad complex QRS. Okay, fine. Now let's move one step further. So the first wave in the QRS is known as R wave, and the second wave is called as S wave. So there's a R wave and then there's a S wave. So what is the interval of a RS? So RS interval is more than 70 milliseconds. This is known as Brugada sign. Now, let me look at another diagram which is on the lower left side. What I can see there is that something is happening. There's a slurring in the downslope of the QRS. There's a slurring in the S wave. Okay, this is a S wave coming downward is the S wave. So there's a slurring over here in the downslope of the QRS. Where you will see them? You will see them in the precordial leads, V1, V2. These are again prominent features. So we'll move on to the next thing. You will see a RSR dash pattern. What is this RSR dash pattern? So this is R wave, then there is a S wave, and then there's a R dash wave. So a rapid air with a long first and a short second is a very much feature of a ventricular tachycardia. But if you have a short R and then a big R, this is a feature of a supraventricular tachycardia, not a ventricular tachycardia. So rapid का कान, तो जो पहला कान है इसका, रिमेम्बर इट फ्रॉम दिस डायग्राम है, सो उसका जो उसका पहला कान होगा वो बड़ा होगा रैपिड का, एंड सेकंड कान जो होगा छोटा होगा, तो दैट इज अ फीचर ऑफ अ वेंट्रिकुलर टैकीकार्डिया. एंड अगर ये उल्टा हो जाता है, अगर ये उल्टा हो जाता है, जो उसका पहला कान है वो छोटा है, अब दूसरा कान बड़ा है, दैट इज अ सुप्रावेंट्रिकुलर टैकीकार्डिया. I hope these things are clear. These are very, very important. I will repeat it once again. Yes, we'll repeat it once again. There are fusion beats. फ्यूजन बीट बहुत सिंपल है कि पी वेव जो है प्रीमेच्योर वेंट्रिकुलर कॉम्प्लेक्स के साथ फ्यूज हो गया. कैप्चर बीट क्या है? कैप्चरिंग ऑफ अ नॉर्मल क्यूआरएस रिदम. कहाँ से आ रही है? नॉर्मल वेंट्रिकल से आ रही है. फाइन. फिर हमने क्या देखा? कैप्चर बीट्स, फ्यूजन बीट्स देख लिए. देन उसके बाद हमने क्या देखा कि क्यूआरएस की कॉन्कॉर्डेंस होनी चाहिए. दैट इज अ फीचर ऑफ वेंट्रिकुलर टैकीकार्डिया. अगर तुमको नेगेटिव कॉन्कॉर्डेंस मिल जाए, दैट इज अ टिपिकल फीचर ऑफ अ वेंट्रिकुलर tachycardia. Fine. Then we saw that the RS pattern more than 70 millisecond is a Brugada sign. And if you see in the S wave, the downslope, you see a slurring of the S wave, especially in the precordial leads. This is known as Josephson's. Then you see a rapid air pattern, capital R, small r pattern. What are the types of ventricular tachycardia? We have a non-sustained ventricular tachycardia, sustained ventricular tachycardia, where the duration is of more than 30 seconds with a stable and a uniform QRS. And then you have a polymorphic ventricular tachycardia, where you can find a different QRS morphologies. PMVT, Torsades P pointers is one of the PMVT types. So what is the management of the patient coming to you, the ER? So if the patient is coming to you in the ER of a ventricular tachycardia, first of all, you have to see the vitals. You have to look at the SpO2, respiratory rate, blood pressure. Patient should not be in shock. If you find that the patient is in shock, give a DC cardioversion, where it is given in a synchronized manner between the two RR intervals. If you find that the patient's BP is fine, patient is stable, but the ECG shows a ventricular tachycardia, the drug of choice becomes amiodarone. What is the dose? It is 15 mg per minute for over 10 minutes, followed by 1 mg per minute over 6 hours infusion, followed by 0.5 mg per minute over 18 hours. Okay. And the next thing that we see is, now you have started the patient on amiodarone. You will put the patient on the long-term amiodarone tablets. What is important is that you have to get a yearly ECG. The second important thing that we need to do is a chest X-ray to look at any interstitial lung disease or the pulmonary fibrosis, because long-term amiodarone is known to cause IPF, idiopathic pulmonary fibrosis. Again, you have to go for a pulmonary function test with the diffusion of carbon monoxide. Then you have to get liver function test twice yearly, because amiodarone is known to increase the SGOT-PT levels and cause amiodarone-induced hepatitis. Then skin examination twice yearly is very important, because amiodarone causes bluish discoloration of the skin. Then thyroid function tests are very, very important, because we all have heard amiodarone-induced thyroiditis. CNS examination, because it is known to cause psychosis, and eye examination every yearly to rule out vertex keratopathy. Now, what is the management of ventricular tachycardia? If it is an unstable patient, you have to go for electrical cardioversion, and what it will do, it will make the tachycardic heart momentarily refractory. It will stop for a moment, and then they will take over the normal pacemaker activity. But then, what is the width of this slide is very important. Why it is important, I'll let you know. So you see why this slide is important, because DC cardioversion and defibrillation are two things that almost everyone is confused. I was also confused before reading it, before extensively reading it, again forgetting it, again reading it, because yes, um, the words look very similar, but the functions are totally opposite. Okay. So now, what is a cardioversion? What we are saying कि किसी हार्ट में वेंट्रिकुलर टैकीकार्डिया हो रहा है, तुमने क्या किया, तुमने मोमेंटरली एंटायर मायोकार्डियम को स्टॉप कर दिया, रिफ्रैक्टरली स्टॉप करके उसका नॉर्मल साइनस रिदम आ गया, उसने अपनी नॉर्मल पेसमेकर एक्टिविटी ले ली. Okay, so what you do, you give a shock between two RR intervals, you give a synchronized shock between the two RR intervals. Okay, what is the advantage? There's a less of the energy use. If it's a AFib, you use 120 to 200 joules. If it is a atrial flutter, you use 50 to 100 joules. Now, what is a defibrillation? You are defibrillating. There's a fibrillatory waves, and you are defibrillating. You are canceling those defibrillating waves to make it to the normal sinus rhythm. There it is done in the ventricular fibrillation and in the pulseless ventricular tachycardia. And this is an unsynchronized DC shock. No time is spent to find the RR intervals. You just have to give the shock irrespective of the RR interval, and you give a higher energy, that is up to 360 joules of energy is consumed. Now, this is very important because the dose is usually forgotten, and that is a havoc if you forget a dose in the emergency. So amiodarone, always remember 15 mg per minute for first 10 minutes, that make it 150 mg over 10 minutes IV, followed by 1 mg per minute for 6 hours, and then 0.5 mg for next 18 hours till reversion. Maximum dose is 2.2 gram over 24 hours. Fine. And it has a slow onset of action, and patient is at risk of hypertension. That is why we do not give amiodarone in patients of unstable patients. Second is, if amiodarone is not available, you have IV lidocaine, which is given as 1 to 1.5 mg per kg at a rate of 25 to 50 mg per minute, and it is easier to administer. Then we have IV procanamide, 20 to 50 mg per minute until arrhythmia terminates. Fine. And what is the advantage? They have a rapid reversion advantage. Then beta blockers, this is called pill in the pocket therapy. Why beta blockers in these patients? Because the patient is going to get a multiple arrhythmia, so the patient should have a beta blockers in the pocket. It's a universal indication to start the patient on beta blockers. And why non-selective beta blockers? Because they have a prominent myocardium effect on beta 2 as a beta 2, and it has a very good CNS penetration, and they have a reduced sympathetic drive. Beta blocker of choice is propranolol, and for the rapid action, you may give acemalol. Long term, you give a beta blocker as initial management. For the long term, you have to give a implantable cardiac defibrillators. If the patient is, you know, uh, when are you going to give a radio frequency ablation? So radio frequency ablation given the patients in the where the multiple ICD shocks has been given despite antiarrhythmic therapy as a substitute to the antiarrhythmic therapy, and in the refractory ventricular tachycardia. So there are three categories. If the patient is asymptomatic, non-sustained ventricular tachycardia is there with reserved left ventricular ejection fraction, you need not give any therapy. If the patient is symptomatic, you should start the patient on beta blockers. And if the patient is symptomatic, non-sustained with ejection fraction less than 35%, put the patient on ICD. Polymorphic ventricular tachycardia, Torsades de Pointes will come inside it. Brugada syndrome, which have a coveted ST segment with T-wave inversion. You have a catecholamine polymorphic ventricular tachycardia and early depolarization syndrome. It also occurs in the patient elderly who has an underlying structural heart disease, and in the young patient with a history of hypertrophic obstructive cardiomyopathy. So now this is a polymorphic ventricular tachycardia where there is a cycling of the QRS to 180-degree. Drug of choice here is the magnesium sulfate, 1 to 2 gram IV bolus. It will normalize the magnesium levels, and if the patient does not respond, you can give a temporary pacing, or you can give a ISO proterenol to the patient, and the definitive therapy is a ICD insertion. In the congenital long QT syndrome, we give beta blockers. Now, Brugada syndrome, it is very important. It is asked in the vivas and also in the theory. It is I haven't personally seen the case of a Brugada syndrome till now, but yes, cardiologists do find it very commonly. So what are the other names? It is called as Puri death syndrome or the SUNDS, sudden unexpected nocturnal death syndrome. The patient will have syncope, they will have sudden death at night. So what we can see in the ECG, there is a coved ST elevation, the V1, V2, and V3 with T wave inversion, V1, V2, and V3. What is the treatment? It is implantable cardiac defibrillators. Now, what are the anti-arrhythmic drugs? We have class 1, 2, 3, 4, and 5. Class 1 is a sodium channel blocker. Class 2 is a beta blocker. Class 3 is a potassium channel blocker. Class 4 is a calcium channel blockers. And then we have, so where are they going to work? So class 1, where class 1 is going to work? Class 1 is going to work on this slope. So the first slope, class 1 is going to work. It has three further classes, group 1A, group 1B, and group 1C. We'll see what is happening. So sodium channel blockers are going to work on a slope of phase 0. And we have three categories inside it, 1A, 1B, and 1C. 1A is quinidine, procanamide, diisopyramide. Class 1B is lidocaine, phenytoin. Class 1C is flecainide and propafol. What are the side effects? Quinidine, we all know it causes hemolytic anemia, thrombocytopenia. Procanamide causes drug-induced lupus. Lidocaine causes dizziness, confusion. Then we have beta blockers. Beta blockers, they are chronotropics and bromotropics, so there will be a decrease in the heart rate and conduction velocity. So what are the drugs? Propranolol, esomeprazole, metoprolol, and tasbutolol. It is contraindicated in a patient of acute decompensated heart failure, in the patient of asthma, bradycardia, and hypertension. Then we have a potassium channel blockers, which are going to increase the action potential, duration, and they are going to increase the effective refractory period. What are the drugs? We have amiodarone, sotalol, ritilium, and drondilone. What are the side effects? We have already seen. Then we have a calcium channel blocker like verapamil and diltiazem. They tend to cause AV blocks, hypertension, bradycardia. Then we have others, adenosine, magnesium, and digitalis. So I will discuss the antiarrhythmics in the another lecture that will be typically on the antiarrhythmic drugs, so that this lecture doesn't get very long. So this is how intracardiac defibrillator look like of the company Cardens. It is kept in such a way. What are the advantages? It is superior to the drug therapy. Second, it reduces the risk of a sudden death. Now, what are the indications of the implantable cardiac defibrillator? The patient who have a document ventricular tachycardia or ventricular fibrillation, cardiac arrest, which is not because of a reversible causes. Second, in the familial and inherited conditions like long QT syndrome, hypertrophic cardiomyopathy. Then in the documented MI with the ejection fraction of less than 30%, either 40 days following a medical management or 3 months following revascularization. So let me simplify it. Patient who has undergone a previous cardiac arrest, who has a history of ventricular tachycardia and ventricular fibrillation, which is not due to a reversible cause. Second, patient who has recently undergone MI and is having a heart failure with reduced ejection fraction. Along with that, he's on a medical management since last 40 days or revascularization in last 3 months. Patient has a dilated cardiomyopathy, maybe ischemic or non-ischemic, with the ejection fraction of less than 35% and is on a medical therapy from last 3 months. And patient who have a grade 4 NYHA symptoms, he needs a cardiac revascularization therapy. Okay, so what I am going to do is I am going to discuss antiarrhythmic drugs in the another lecture, which would be exclusively for the antiarrhythmic drugs with the dosage, side effects, so that that lecture could be listened carefully and could be responded accordingly. So you can ask your questions in the comment box. Thank you.